Okay, hello everyone. Welcome to my course about aligners, right? The aligners intensive with OHIS. It's a pleasure for me to be here in this webinar number 2 for those who are starting by this one, because this is a course. You can see the recordings later. You can buy individually each webinar, so it may be your first webinar now. So my name is Daniel Ramos. I am from Brazil. I'm orthodontist. I'm practicing orthodontics for 20 years, right? I am guest faculty in 2 institutes in the University of Murcia in Spain and also in IHDS in Houston, USA. Right now I'm working here in Spain, Madrid. I'm not in Brazil anymore. I'm taking care of my patients virtually, but I am the DSD Planning Center Ortho Clinical Manager. I'm also a QOL for DSD Invisalign, and again, I'm focusing my practice in aligners, and we are dedicating these 4 webinars. We already did the first one. If you miss it, it's there recorded. Don't miss it, because I provided very important information about digital diagnosis. Okay, and today we're going to start talking about biomechanics. Of course, this is a topic when we are discussing orthodontics that we are going to go deeper more and with clinical cases when we start describing all the malocclusions and how can we treat them with aligners. But at this moment, until webinar number 4, we are going to review all the concepts, and today we're talking about attachments and staging. Okay, I think this is a super important topic when we want to treat patients with aligners, because without them we can lose a lot of predictability. So we have basically these 3 let's say biomechanical features that we can add, such as attachments, staging, and now auxiliary resources that we're going to start discussing next webinar. Okay, and also the artificial intelligence that can help our intelligence, because this alone cannot do anything. Okay, be sure of that. But today we're going to focus in the first 2, okay, attachments and staging. But it's important, of course. I won't waste a lot of time here. I just want to give a brief review about the evolution of orthodontics from these bands with wires to the edgewise system and static braces, lingual braces, until we get to aligners. A lot of things have changed, of course, but we think aligners is new, attachments a new concept. Of course, here is just a joke. This is not attachments. But the biomechanics, considering orthodontics, is very old, okay? And the modern orthodontist started in probably 1890, okay, with Engel, and his discoveries about creating anchorage and using wires. And most of these concepts we brought to aligners, okay, to understand how we can move teeth in a different way. So aligners has not started with Invisalign, as many may think about it. Okay, in 1994, Harold Castling was the first one to create a system, a removable system, static and like this, because as we can see here, it's not that static, where he can do setups and change the position of teeth with this plastic appliance. Okay, so the patient use and the teeth start moving. So this is considered the first aligner, and then Henry Nahum invented this a vacuum former machine to create a better material, right? Not the old one in 45, which was very big, and now a thinner plastic. And in 1993, and take a look, Invisalign started just a few years after this, the ASIC system was invented, okay? And this system started with a lot of concepts that we are using until nowadays, okay? The use of pliers to help creating bumps and to help creating point of pressures, the use of burrs to do selective trimming, IPRs, and also to create cuts in the aligners, the use of separators in order to help creating space, elastics, and IPR. So a lot of concepts and improvements in the aligner system in 93 was invented by this group of dentists who created these systems, okay? So this is something that some aligner system, they have developed new solutions, okay? And they have solutions that came with the aligners, but not all have access to the system. So I would like today to share my experience, not only with Invisalign, or with Essex, or with Sure Smile, but for those who want to do the aligners in their office, concepts that can be used for everyone, okay? So bumps are the opposite of attachments, because attachment is something that we're going to bond in the tooth surface, and bumps we create in the plastic to create this kind of point of pressure when we want to move teeth, okay? This is something that was created in 1993. Also creating hooks and cuts. We have pliers to do that in the aligner, or you can order directly to the company to provide this, okay? We can create buttons, we can do a lot of things with pliers, and you can find these pliers in probably most of the orthodontic suppliers nowadays. Just ask for aligners pliers, okay? This other one you can create, for example, bite ramps. I am anticipating a lot of things that we are going to discuss further, okay? But this technique that we need to use pliers and burrs and develop using our own hands in office with our lab, the aligners, it has some downsides, right? Some downsides, because it's a very sensitive technique. It depends on a good lab or in a good orthodontist, and it takes a lot of chair time, a lot of lab time, and you need to invest in a lot of equipments for your lab, okay? And for each stage you need to do everything again. So in my experience, and I started in 2008 with aligners, in my experience, I tried to use, and when we have few patients, it's very good for those who likes to work in the lab, and I am one of those, okay? But when I started having more patients asking for aligners, I saw myself a lot of time in the lab, a lot of time adjusting, and this time for me is valuable, okay? So nowadays I prefer this system that it was created in 1997. I prefer to use a company for this hard working, okay? And this is something that the patient is going to pay for, okay? And I'm going to be there to do the thing that I like more, that is to do the treatment planning and to develop all the sequence and everything else. But it was in 1997, and of course not dentists, two engineers from an MBA students in Stanford, they created this CAD-CAM technology to orthodontics, and the evolution probably you all know, from 97 until nowadays, a lot of things happen, okay? But for me, probably the tipping point for me was in 2014, where they developed the CleanCheck Pro with 3D controls, a software that a lot of other companies are now developing very similar, some with extra features, others we don't have this control. But what happened here, more important than all others evolutions, transformations, it was that now as orthodontists I can control the software, and I really like to do this, okay? So today, about attachments and staging, I would share with you how can we do manually, okay, by our own hands in the CleanCheck, and also how can we order to the technician when we don't have this feature to control the software, okay? But let's start by the concept, okay, attachments. When we start talking about attachments, it's important to understand that it's something temporary, something that we're going to use during the whole set of aligners, okay? And as a concept, it's a composite bump, okay? Something that we are going to bond over the enamel, okay, in the tooth crown, and can be lingual, can be on the buccal side. Sometimes, depending on the position of the tooth, we can place depending on the force system that we want to create. One of the most important features of the attachments is that the advantage of using to improve aligner retention, okay, because when we don't have the plastic holding the crown completely, we sometimes start creating forces or movements that we don't want. Okay, so to keep the aligner there is very important. Sometimes the attachment is not there to promote any movement, but just to keep the aligner well seated. Okay, and by doing this, we're going to improve the force system. Okay, because what we are creating in the software, and this is something that this course is not going to talk specifically about one software, although I'm going to use for my cases Invisalign as a reference. I don't have anything exclusivity with them. I want to always make this clear, okay? And what we want to do is create force systems, and the attachments are very important for this. With attachments can allow us to do specific movements. For example, in a very expulsive crown, for example, a cuspid, where we want to extrude the crown. Imagine we trying to do with plastic, holding only the crown. It's not going to keep the aligner well seated, and then the aligner is going to extrude, but the crown and the whole tooth is not, right? So the attachment is going to help creating a point of anchorage, so the aligner can pull the teeth to the center that we want, okay, to the direction that we want. And of course, by doing this also we can create anchorage. For example, when we want to intrude the lower anteriors, okay, we are going to create the plastic to create pressure to intrude them, okay, but we need to keep the posteriors in a position, otherwise the same force that is going to move to pressure the anteriors down is going to move the aligners up, and then if we don't have attachments there, we're going to lose the stability and we're going to lose tracking, okay? The tracking is another word that I'm going to use a lot. So it means kind of predictability. It means how much the teeth is moving according to what we have specified in the aligner, in the plastic, okay, for each stage. So if for some stage we plan to do this and the tooth do exactly this, it means that we had 100% of predictability. So we need to keep tracking the movements and tracking if the aligner and the tooth is following what the aligner is saying, okay? Considering attachments, we have two types of attachments, okay? You can see here the images, okay, how it is represented, and it's very similar for most softwares, okay? This is these structures here. It's not part of the tooth, it's not a restoration, it's not in the plastic. It's a simulation where we are going to bond in the crown, and this is something for those who doesn't know. I'm going to provide a very clear step-by-step process with how I believe it's the best way to bond attachments and also to remove them later, okay, also very important. But the conventional attachments are those who we have available in the software that we by ourselves can place and change the position, increase the size. So they have specific shapes, and then we can position in the way that we need using this control. So every time we click over an attachment in the software, when we are the software that allow us to do this, because some softwares doesn't, okay, and we need to write to the technician from the company to say, please insert a rectangular attachment, and then this is important for us to understand how to describe this, okay, and let's discuss this in this course. But the conventional, when I talk about conventional, are those there are specific shapes, okay? I'm going to explain what are these shapes, okay? And then this is something that Invisalign developed, the optimized attachments. These attachments, they come from the technician, the software, and they don't have one specific shape and size to depend on the movement that we are doing, okay? And then they have not only the attachment itself is going to create force, but also the shape of the plastic changes, okay? Let's discuss this in a few. But talking about conventional attachments, I always like to remember like this wall, climbing wall, where we need to have points to put our hands in order for us to climb, right? Otherwise, if we don't have a very good surface here to have a good point of anchorage for our hands, probably our hands are going to slip and then we're going to fall, okay? And the same thing happens with the aligners. If we don't have an angle there, a surface that the aligner is going to hold it and put the force where we need, when we start doing the force is going to slip over and then we're going to lose tracking, okay? So when we talk about attachments, remember this, okay? So the attachment here, right? The same way for the climbing wall, imagine this hand that we need a surface so our fingers can create a good hook there so we can put force for to climb. It's exactly the same, okay? So you always, by understanding this, okay, we need to understand that the surface, the bigger surface, okay, it's you need to face it against the center, the direction of the force. So if we are extruding this crown, as this arrow is indicating, so we are moving this crown down, okay, we need to adjust the attachments, moving this surface, this flat surface, against, like a mirror, okay? We need to put the mirror against the sun, okay? So if we want to reflect the light, okay? But here it's a force, so the aligner is going to start changing this shape, moving down, and we want to bring the two together, okay? So we always need to face this surface against the force, okay? Mostly for the cases where we are just, it's not a optimized attachment and we need to create a retention so the force system is going to be increased, okay? So this is the goal number one. Conventional attachments, they can also work as anchorage, okay? We don't want to move something, okay? And this is a good example here. For example, a class 2 where we are going to use an elastic. So this, let's start anticipating the top for the next webinar. When we see these cuts here, these lines, these blue lines means that here is going to be a cut in the aligner where we can fix elastic, okay? Don't worry about this right now. Let's discuss more next week, the next webinar, okay? But we just need to move the uppers back distal, and we don't want for the elastic to pull out the aligners here. So if we don't put this attachment here, even if we're not moving this to this 3.6, the elastic is going to force the aligner out. So we need to use attachments to lock the aligner in position. So a conventional attachment is very good to this. And why I place this way, look, to this surface facing down, okay, and this other flat surface facing distal. Because our force is exactly a composition of these two angles, right? We are coming from this point to this point, okay? So I want to hold the extrusion component of this force, and also I want to hold, avoiding, to keep the aligner there, avoiding moving mesium, right? So this is how we figure out the position of this attachment, okay? We have basically, and this is something that I am researching pretty much, all companies, they are using these three kinds of conventional attachments, okay? We have this ellipsoid, which doesn't have a flat surface, it's very rounded, okay? Usually there is some difference between one company to the other, but usually they have these measurements, okay? Then we have a rectangular attachment, okay? Flat rectangular attachment, so we have the same depth for both sides, okay? And we can change in terms of height here, okay? Can be 3, 4, 5 millimeters, depending on the company, can be less or more, okay? But usually is these measurements, okay? So depending on the size of the crown, the space we have, we can change between 3, 4, or 5, but this is a very good attachment to use for retention, okay? And the one that I like more, okay, is the rectangular beveled with this angle here. So we have this big surface inclinated, and then we can select the size, the side we want to inclinate, depending on the force, okay? So this is very useful for us, and I'm going to explain why it's better to use this model than this model for most of the situations, okay? Remember, please take notes of your questions. I have the team of OIS helping me here, and at the end of the webinar, all the questions I'm going to answer, okay? And if we need, we can come back here to these slides and review everything, okay? As usual, I prepare a lot of material, and probably knowing myself, I'm going to surpass the time of 1 hour. But feel free if you need to leave. It's going to be recorded. You can watch for 30 days, so no worries, okay? So this ellipsoid, the first characteristics is that the retention is weak because we don't have a flat surface. It can easily, imagine this attachment here in a wall and you're trying to climb. You don't have much surface to place your fingers, and then it's going to slip, and probably it's going to be very hard for you to keep your hands there, okay? So what's the purpose of these attachments here? Since we can create a very small force support. The only indication, at least for me, I don't know if it's the same from the companies, okay? But in my experience, when we have temporary teeth or provisional crowns, where it's our interest to not have a good retention. Okay, we just want to increase and improve a little bit the retention to have the aligners well seated there, but we don't want to create much force in the temporary crowns when we have some mobility, or in provisionals where the aligners can remove the crown when the patient tries to remove the aligner. Okay, so when we really need to place an attachment in provisionals, and it's just for retention, we don't need to move a lot the tooth, I like to use this, okay? For young patients in mixed dentition, where we want to, when it's completely possible for us to treat them with aligners, but we have very short crowns sometimes, and we need to improve retention. Also, this kind of attachment is very useful. But besides these examples, I really prefer the others, right? I think they work better with better force system, okay? The conventional attachment, the rectangular one, okay, with all flat surface, the same size, the laterals, and a big rectangle in the crown, okay? The retention force is strong, okay? The force support is medium because the walls that we use as force support, let's say this way, are the laterals, okay? Because this front one is going to be parallel to the surface of the crown, okay? And we already have all the crown to do the pressure there, so we are not going to use this surface here. So we are going to use the laterals, okay? So when we are going to use this attachment, mostly for when we don't have optimized attachment, because the optimized attachment for binary forces are very good. When we need to mesialize or distalize a crown, okay, let me take this remote control. If we want to close a extraction space, or we just want to do a translation of the tooth, this one is good because we have a lot of lateral surface to create a binary force. So when we start moving, we can have this, and I place in a vertical, also works in horizontal, okay? One thing that we are going to learn when start treating patients with aligners, that there is not only one right way to do with attachments, okay? I can see a lot of different doctors using different kinds of attachments, and others don't using attachments at all, depending on the way they plan the software. It's possible, and we can have good results. But my opinion, and here you are discussing with me, is that for retention mostly, the more the better, the bigger the better, okay? I know patients they don't like, but if we really want to improve predictability, we cannot leave tooth that we are moving without attachment, only for inclinations probably, but this is another topic, okay? So this attachment here to root control, okay, when we need to move the crown and bring the root together, binary forces, because we have a very big and two lateral walls here, okay, and when we want to place fake attachments, that's something that we're going to discuss in the next webinar, okay. I'm not going to, because we have a lot of things to do, I'm not going to stop here. And for me, the best one, okay, the one that pretty much I use in all my cases is this rectangular beveled, okay, that we have this big surface inclinated and we can play with it, changing the position and moving according to the force that we want, okay. So the retention is a little smaller than the other. I can't say that it's moderate, but it's enough if we work with more attachments in other teeth. And for the force system is the best one. We can have the biggest surface possible working against the force direction, okay? So you can use for extrusion, retention, mesial distal movements, pretty much all movements, all the movements that you can use the other, you can also use this one, okay? Here, it's a good article that evaluated all kinds of attachments, okay? You can access the article here if you want to download. It's just a matter to use your camera to this QR code, okay? All of you know this, of course. The study used the ASIC system, okay? And another kinds of aligners, and the ellipsoid, as I mentioned, and I was using my experience, my clinical experience, but also I'm basing myself here in articles, show no significant effect on retention in the aligner, okay? So if you really want retention, avoid using the ellipsoid, okay? Only use for the situations I mentioned, the serious crowns and provisional crowns, okay? Another study about attachments, when deciding, depending on the case, if we're going to bond on the lingual face or the buccal surface, this is something that these studies start changing my mind, because in the beginning I struggled to have good results depending on the case, placing the attachments in the lingual side. I know this is very good for the patient, okay, but for us it's more difficult to place. And depending on the case, it's not as effective as placing in the buccal surface, okay? But this study showed us that the result, as we can see here, the displacement, it's the best one, of course, where we have more movements or placing in the buccal side, okay? And then very close to it, but a little less in the lingual side. So it works. We have more cases, more and more, mostly for the upper anteriors, okay, because placing an attachment big like this in the upper incisors, it's hard for the patient. Sometimes they don't like, and sometimes no, all times they don't like. And we can try to help them, depending on the situation, depending on the movements, to place in the lingual side, okay? Mostly when we have them for retention, we can bond there, okay? When we need to use binary forces to close spaces, I prefer bonding in the buccal surface, explaining to them that we can have a better result here, okay? But again, good result with the lingual attachment. Another importance of using attachment, I really recommend you to read this article, and when they mention this watermelon seed effect. So if you imagine yourself with a watermelon seed in your hands and try to with two fingers make pressure, it's going to slip and it's going to move out, right? And this is what happens when we are sometimes moving an incisors that has a shape very similar here with the attachments. That is something that is creating pressure. So even if we start just a simple movement like a crown buccal inclination, okay? If we start moving, we are going to start having contact in this area here, okay? And then we're going to have contact in this area. It's more or less like doing this with the seed of the watermelon. And we have an intrusion component here. Then we start to also intrude. If you want to procline the crowns and intrude, amazing. You don't need to place an attachment here, okay? But if you want, for example, to avoid intrusion, and or if you want to extrude, for example, to place an attachment in this area is very important. Otherwise, this is something that usually happens. You start seeing the aligner in one position and a space between the aligner and tooth, like you can see here, okay? Why this is happening? Because you can see here we have an attachment, okay? We can see clearly by the shape of the plastic, but even when we place attachments, depending on the size, and this is a very small size, in this case happen this effect, okay? As soon as we start moving, this pressure in the incisal part of the crown start creating intrusion component of force, and then we start losing tracking, and this is a very good example of losing tracking. The tooth, the crown, it was supposed to be here, well adapted to the plastic, and it's there, so we have almost 1 millimeter here in distance that we lose tracking, and then we need to know how to recover this, okay? We're going to have a whole session here to discuss troubleshooting, how to solve this kind of problems, okay? But stay tuned, okay? How to position the rectangular bevel attachment, okay? If it's important to place in an incisor, as I mentioned, okay? The first rule, the more distance we have between the attachment to the gingival margins, the better, okay? Why is that? Because we need to have contact between the plastic and the surface of the crown, okay? If we place closer to the center of the crown and more in the incisal edge, we're going to have this distance here in this area, okay? And then we can have a lot of force there holding the crown in position. If we move, sometimes the patient asks us to be the more static possible, and then we want to move up to avoid showing the attachments, and we have only this distance here, okay? Why this is a problem? Because sometimes this attachment pulls the plastic out, and then we don't have enough force of this plastic between the attachment and the gingival margin to bring it back. Okay, this is just a minor amount of plastic here in this area, okay? So when placing in the vertical position the attachments, we want to place them at least in the middle of the crown, but ideally more close to the incisal edge. This is something that after years seeing a lot of congresses, discussing cases with colleagues, and in the DST, we have a treatment planning service where we are doing a lot of cases. This is a consensus, something that we understand that is much better to do this way and not this way, okay? Also, even if we position in the correct vertical size, there is a best way to inclinate the angle here, the bigger surface, the bevel, okay? And usually I like to inclinate them to the cervical line, not in the incisal edge, because remember, we want to have this surface being faced against the force, okay? When we would place it down, like we are seeing here, if the force is coming up, right? But to this force, we have the whole crown and the whole plastic holding there, and we don't need a surface, okay? So why we place up? Because for this situation, we are just using the attachment for retention, okay? If we just need to intrude, then we don't need an attachment. We just need to leave it, and the plastic is going to have all the incisal edges and the crown to work against the plastic, against the crown, to do the intrusion. But if we want to do inclinations, we want to avoid intrusion, or we want to rotate the crown, and we need a retention in order to achieve this, then we need to place an attachment, and then this is the ideal position, okay? And then I'm going to show, I believe in the next slides, for us to keep the aligner in position well seated with a good tracking. It's easier here than here, because the minimal movement then we have of the aligners out we're going to have this surface, this ramp, moving the plastic even more down, okay? But let's show some images in a few for you to understand, okay? So when the tooth is losing tracking, when we place like this, for example, imagine the other image that the plastic was down and the tooth are up. If the plastic is going down, this ramp here, this surface is going to make the plastic leap up again. Okay, this is where we are stimulating, so it's going to facilitate this. Okay, and here in this case for retention, as I explained, we have initial this spur curve. We want to intrude the anteriors and we want to extrude the posteriors. Okay, this is the final position that we want to achieve, the overlapping between initial and final. If we want to intrude, the plastic doesn't need attachments here because we have the crown and now the incisal edges here as a surface, so the plastic can move down, okay? But here, the crowns are expulsive, right? If we don't have something to hold, we're going to lose tracking. And this is the ideal set of attachments for this case, okay? Where we are placing these rectangular attachments on the tooth that we want to extrude, okay? And this bigger surface down because the first is going up, okay? And with this strategy here, we can increase a lot the predictability for this kind of correction, okay? So this is in another angle, okay? For the intrusion, we already have all the crown, the buccal surface, the lingual surface, the incisal edges, all working as a big attachment, okay? And here we inclinate the attachment, the surface down, so we can have the force being inserted against this wall here, so we can have more efficiency, okay? Let me know later if I'm going too fast and if you want to repeat some of these concepts, okay? With the cases, when we start looking like this for conventional attachments, it starts to become easier because you plan the final position that you want, and then you can see the tooth moving to this final position. So we can understand the direction of the movement. And then you can start placing the attachments or changing the attachments for the system that already came with attachments. So by understanding the start point and the final position, you can clearly see the direction and the force that the elastic is going to provide. So then you will understand easier if you need attachment facing the big wall, the big surface, in which direction, okay? And then we have the optimized attachments, okay? Here is something that we don't have control. We can only select if we want to remove and change for optimized attachments. In some situations, we can ask, let's say Invisalign, because it's the only company that is working with this kind of attachments nowadays, as far as I know, okay? You can ask to include them, but when it comes with optimized attachment, we need to evaluate if it is worth it to keep them or if we need to change. And then this is a very clinical evaluation, and we need to understand why the optimized attachment is there, okay? So here you can see a case with our attachments here are optimized. You can note that each one has a specific shape, okay? These are very close one with the other, but they have different shapes here, completely personalized for the movement that we want to promote here, okay? So it's like comparing, you are going to buy a suit, you can go to Zara and buy one that is there, or you can do a tailor-made for you specific with your measurements, okay? This is the explanation for optimized attachments. So they can create a combination of anchorage and rotation with a force system, because the plastic also has points of pressure where it's going to create forces in a different way, okay? Can I explain more than this, explain exactly what happened? This is kind of the Coca-Cola formula for Invisalign, right? So they don't explain much about it, but I can understand when it's better to keep and when I prefer changing for you. So this is a decision that you can make, And again, I have a lot of colleagues, they never change optimized attachments, others they change all of them. I try to be in the middle. Sometimes I like to keep them, sometimes I like to remove them, okay? So considering efficiency, this article from the American Journal evaluated and compared different difference between optimized versus conventional attachments, okay? And they didn't find statistically differences, okay, between the two, okay? So they are very similar one with the other, okay? And also these other companies, this other study, sorry, did a retrospective study, okay, comparing a lot of different systems, okay? And the conclusion, with more companies offering clear aligners and the emergence of the in-office 3D printer, one can feel confident in knowing that conventional attachment types may just be as effective as Invisalign optimized attachments. So you don't need to bore yourself if you don't have access to Invisalign. If you prefer using another company, you don't have optimized attachment, but this is not the thing that is going to make your treatment better or worse. Okay. So here, as I promised, when to opt for the conventional attachments. What are the situations that I would like? When, of course, I don't have Invisalign, okay? When I'm treating my patient with other system. When, for this specific movement that I want, it doesn't exist a proper optimized attachment, and they don't have solutions, optimized attachment solutions for every kind of movement, okay? Sometimes they offer you a conventional attachment, or they don't have a good one for me, okay? And this is important, and this is something that in Invisalign you can check by just moving the mouse here over the attachment, and it's going to pop up a box explaining the main reason why this attachment is. For example, if the attachment is for rotation, it's going to be there written, optimize attachment for rotation. But imagine that rotation is not the most challenging movement. You need to, I don't know, move mesial 3 millimeters and you want to create a binary force. Why they are going to place one for rotation? They're going to just keep the bigger number, okay? Maybe this example is not the best one. Let's change the example. Imagine that you need to rotate less in terms of what you need to inclinate the crown, okay? But since the crown inclination has a bigger movement in terms of distance, the software is going to recognize it as the bigger movement. The attachment, the optimizer is going to be focusing on this movement. But we know clinically that rotation are more challenging, right? And we need to have a better force system. So for this situation, if the attachment optimizer is focusing in the inclination and not the rotation, I like to move. And this is what I mean with this item number 3, okay? And also, when we really need anchorage, for example, here, the example that I showed you before, we need to intrude the anteriors, and here we need anchorage. And we have a very tiny optimized attachment just to do a minor movement of rotation that we know that we're going to lose tracking for the movement that we really want. So I am changing because I want anchorage, okay? And also, although they are very similar in terms of anchorage and tracking, keep the line seated, both work the same way. For the same reason, when I realize that this is something that's not going to create retention for the plastic to be held over the two crowns, okay? These are the situations. Let me put again, okay, here, just for us to brainstorm very fast, okay? All the other situations, if the attachment is optimized, it's focusing on the most challenging movement, and it has a proper size, a big size, I like to keep them, okay? But mostly in the 3, 4, and 5, when I have this situation, I'm changing for conventional attachments. So usually my clean checks, my treatment plannings for Invisalign, you can see a mix of both, depending on the movement, depending on my goals, okay, I am changing or not. Before we move on, okay, we are talking about attachments. We already brainstormed about the types, how to place them. We are going to discuss much more for every case we are going to discuss here, okay? But today, let's focus on the basic concepts, and also I would like to start with some clinical tips for the workflow with aligners, okay? Since we're talking about attachment, I think it's important for us to review how can we bond it, the protocols, and how can we remove them. Maybe as important as the whole treatment, because a lot of times the orthodontist or the doctor who is doing the orthodontic treatment, they can ruin the whole treatment by using the wrong kind of burr to remove attachments and destroy the animal, okay? And this is a very serious topic. But first thing first, right? For my first aligner appointment, I like to start easy with my patient, okay? I never like to bond the attachments in the first aligner, in the first appointment, okay? So my past as orthodontist was like this for my first appointment. I had a lot of material over the table, okay? I need to have my bands, my braces, my brackets, wires, elastics, a lot of pliers, a lot of machinery, and my office was packed of a lot of material, okay? And one of big change of the aligners that nowadays it clear a lot of space for me, okay? I have my computer always with me, because here is where I am doing the plans, I am checking the clinic, and I need to, for our appointment, I have the treatment planning open when I see the patient to compare, to see, to show. They like to see the evolution, to compare it in the screen if they are on track or not, okay? For those who have access, the scanner is a very important tool to help us in our daily routine with orthodontics, with aligners. Pretty much has these three instruments: a mirror, a probe, and a plier, okay? A simple clinical plier. Elastic, some buttons, some composite, not a big deal, okay? This is how much reduced my clinical routine regarding materials, okay? For the first appointment, it's a very educational appointment. Of course, this is the way I am doing, okay? Depending on each doctor, you can have different routines and you can agree or not, but in my experience, the best outcomes I have and to keep the patients motivated is when I use the first appointment to first deliver the aligner number one. Okay, here it is, the material. I open the software and show to the patient all the details. I review, because sometimes we present the treatment planning and what we want to do, they approve, they pay, and then we order aligners. Depending on where you are, it can take more time, less time to the aligners come and pass 15 days, 20 days. And then we are here with the patient again to start. So I like to review the most important details. Okay, so we open the computer, review what we're going to do. And here the patient is with the aligner in his mouth already, having the first feeling about, so I can keep them in the office for a while, for them to have some questions and doubts, to feel the aligners and to try to remove it and place it again, okay? I also like to deliver to the patient a very complete health hygiene kit, okay, to help them to clean the aligners, to keep a good hygiene that is important for the orthodontist. So this is a gift I like to give to the patients. I include in all my treatments, of course, the chewies, these very soft plastic, sometimes silicone tubes for them to bite, right, to help keeping the aligners well seated, and also the high frequency vibration device. That is something that we're going to discuss fast in the webinar number 4, okay, to improve the predictability. And I also like to give them a aligner remover, right? So here I'm not bonding attachments, I'm not doing interproximal reduction, I'm not doing complex procedures. I want to have the patient well educated about the treatment, about how can he clean everything, how to use, how to remove, how to insert, and then the patient goes home, okay? So he can use this aligner for 1-2 weeks, and then I schedule for the second appointment, aligner number 2, to bond the attachments, okay? So here, summarizing, The first steps: review the plan with the patient, review the number of aligners, desired final position, review everything you're going to do in the treatment, explain the next appointment. Okay, it's important for them to come prepared for the next appointment. Install aligner number 1, check if it's well seated, of course. Test with the patient if they can remove and place again. One time with one patient, I bonded the attachments in the first appointment, and then I installed the aligner, and the patient was in a rush. Okay, I need to go. And then he called me 1 hour later, Daniel, I cannot remove the aligner here at home, trying a lot of time I cannot remove. Then, okay, come back. And then I need to do with him, because sometimes it's just a minor detail for them to understand where they need to put the finger to remove, but we need to do this in the office, okay? And also give a mirror to the patient and provide our instruction with them look into the aligner and then make them try to remove in front of you, okay, in the mirror, okay, as they are in their home, not in the small mirror, but ideally in a big mirror in the walls, like they have one in their bathrooms, okay? This aligner removal facilitates a lot. Depending on the patient, they have more difficulties to remove, okay, so it can help removing, okay. So usually I like this area here, the palatal side and the posterior area to remove, because you can rotate the aligner and remove easier and faster, okay. If you don't have this device, this instrument available, or if you don't want to give to your patients, I like to provide this kind of image for them. I have a card where I deliver to my patients with these instructions, okay, and normally the companies, they offer also like a manual for them to understand, okay, so he can use the finger and in the palatal side and the posteriors to remove down, okay. I like to teach them how, with the toothbrush that I give them, I open and I teach them how to brush the aligner, okay, how to clean them. And it's important to remember them, because they don't know these details that for us it's kind of obvious, right? But just use toothbrush and water. I always ask them to not use toothbrush, because they have a lot of abrasive, there's a lot of to remove sorry, I'm missing the word, but all the toothbrushes are very abrasive, right? And they are going to risk to create marks in the plastic, and it's going to retain more bacteria and be less aesthetics, okay? And also do not use warm or hot water, because a patient of mine already did this. I think he was cleaning better, but it deformed all the plastic, okay? I always remember them to, as soon as they remove the aligner from the mouth, to at least to use water, ideally with the toothbrush too, and also clean the box, because the box with the moist and everything else, it's in a very bad condition after 1 week, okay? So my goal in the first appointment, the item number 1, depending on the agenda of the patient and my clinic, I will deliver 1 to 2 aligners without attachments, okay? And this is I only do for the first set, because after the patient is very used with the attachments and we need to order more aligners to keep going with the case, I normally bond in the first appointment. But for the first set of aligners, I deliver 1 to 2 without any attachments, okay? And then if the patient has the Vipro, I ask him to change in 7 days and came back to my office in 1 week or in 2 weeks, depending if I deliver 1 or 2, okay? If he's not using Vipro, the high frequency vibration, I ask him to change in 14 days, and then he can come back in 2 weeks or in 1 month to my office, okay? So the goal here is get the patient used to the aligners as fast as possible to achieve the ideal 22 hours a day. That was our goal, as soon as possible, okay? So facilitate patients' initial adaptation. That's my tip, okay? So leave attachments, IPRs, elastic for the second appointment, chewies at least once a day, this one, okay, to help them keep the aligner well seated, and the Vipro 1 to 2 times a day, okay? I'm wrong here, it's the part 4. but the Vipro, it's something that can increase a lot the bone remodeling process, and then it needs to use only 5 minutes a day biting this mouth guard here, okay? So after this clinical part, and before we start talking about the protocols to bond, the first tip is aligners patient, they don't like frustration, so give them an easy start, okay? This part here about the second appointment, I'm going to move a little bit fast regarding the instruments, pretty much a repetition, okay? I like to have the computer with all the information about what I'm going to do, if I'm going to do IPRs, where I'm going to do IPRs, if I'm going to bond attachments, where I'm going to bond attachments, open for me to have an easy access. And here I will suggest you, this is a very good article with Dr. Chang and his colleagues talking about an efficient way to bond attachment that I really like, okay? And they split in 3 phases: pre-bonding, bonding, and post-bonding, okay? So I really recommend reading this article. I'm going to review for you, okay? They explain 2 techniques, one with a restoration composite, the one that we use for the restorative dentistry, okay, that I recommend, and the other with flowable composite, okay. It's easier, faster, but it's less resistant, where with time, and is easy and can break easier, but again, it's easy and fast to apply. This other one takes more time. You need to apply before the appointment because you need to use an instrument to place and to compensate there, but it's very resistant and won't wear during the treatment, okay? So I like to apply, you probably know, right? But with the attachments, you have a template. I'm going to show you a plastic. It's not an aligner. It's in a specific bag for the attachments template, where we are going to apply the composite over this area where you are going to transfer to patient's mouth, okay? So this way you can be assured that the same attachment that you place in the computer, you're going to transfer to the exact same position by using this attachment template, okay? So you can apply the composite in the attachment with anticipation. Don't leave it to do in front of the patient, because to do with quality, you need to do with a lot of time, okay? If you have an assistant to do that for you, ask her to prepare before the appointment, okay? So with a spatula, you can remove the excess, apply with the spatula. A micro brush, you can spread barrier to compress, to fully fill the template. And then you can store again in the bag that came from the company and inside a black box without any light, because this is a photopolymerization process, okay? By doing this, you can you have several ways to apply. Even for restorative composites, you can use these tips, okay, that you can have a faster filling of the template, okay, and you can check later if you fill all the gaps for all the attachments, okay. They indicate here in the article to paint where you have attachments in black, because this is very transparent, and sometimes we missed one attachment and we bond everyone and then realize, okay, I missed the second molar there. So this way you can remember yourself where you have attachments there, okay? Always important, interesting for you to check the color, okay, of the crowns, okay? So you can use a proper composite to be as much aesthetic as possible for the patient, okay? But if you only have one, if you want to select one, I would use a very clear and transparent attachment. There is those for incisal edges. They can kind of camouflage the color of the teeth, okay? You can bond using the template all the template and bond all together, or you can split in quadrants, which is easier for you to remove, okay? I like to use all together. I don't see a problem to bond all together, okay? Another tip is having the aligner or the attachment template, or I don't like, here they painted, but this is the aligner and I don't like to paint, okay? But I like to have the aligner to check where I need to apply the acid to etch, okay? So I don't like to apply to etch all the surface, only where I will bond the attachments. This is better for us to remove axis after, okay? And during the boning, we need to apply a lot of pressure to keep the template in a position, okay? So we can polymerize and with a good precision. And also always keep with the plier holding against the surface that we are bonding to keep there in position. To remove, I like to use this probe and remove the lingual side if you don't have attachment in the lingual side. So you can rotate this template and move down, okay? This is something that you can read better and with more time later this article, okay? And if you didn't have time to download today in the QR code, later in the recording you can come back, okay? Or ask the OHIS team and I can share with you. The only thing that I don't agree here, okay, is using this burr to remove the axis, okay? I think with a round burr, it's very common for us to create a lot of marks and risks and to create some damage in this animal, okay? I prefer using another burr that I'm going to show in a few. But here you have a good example of attachment boning with a good selection of color, okay? And after boning the attachment is the moment to insert the aligner number 2, okay? For the OHIS team, I will have some delays here for more minutes, okay? Sorry about that. This is a class that I really like to share because it's from a friend of mine, Dr. Federico Brunner from Spain, here where I am right now. He's one of the best dentists that I know, okay? And he is teaching dentists how to remove the attachments, okay? Because a lot of times this is something that happens, okay? We put a lot of effort to move teeth to a beautiful position, and then in the most important part, when the patient they're going to have their smiles, we are in a rush or we don't have enough time, and then we use these burrs, and by using a microscope or augmentation, we can see these defects, okay? And here again. And this is something he's collecting from a long time, patients that he referred to orthodontists, and when the patients came back to his clinic, they were like this, okay? Like this. So this is not the signature that you want for your treatments, right? So it's very simple to make it right? Probably it's going to take more time than removing in a rush, okay? But we need to invest this time, okay? And what he's recommending, and something that I really like also to recommend to you. First, don't miss the opportunity to use magnification, okay? I know this is an investment, but it's an investment for us and for our patient. And this is something that orthodontists, they need to start using more and more, okay? Augmentation glasses. This is something that will open a lot of new windows for you to understand attachments, if it's well bonded, if we need a lot of access, and how much we need to remove. To use the control angle, okay, without water, okay, and he likes to indicate in this velocity 1 by 5, okay, so we can have a smaller velocity to remove and we have more control. And his big trick here is the K light. This is a light that can help us to identify where we have the composite, okay? So by turning off the light of our office and turning on the K light, we can clearly see where we have attachment and composite, okay? Here, if you want to take note or take a print screen, this is the burrs that we are using, okay? Multi-laminated burrs. So we can use in a small velocity, okay? And to polish any system you are used to, as far as it is soft or thin, okay? So in the first stage, this burr to remove the big axis, the bigger part, so it's faster, okay? This is more aggressive, and then you can remove, and then almost as getting to the animal. And when you think you're going to get to the animal, it's time for you to use a probe. You know that, but not a very thin and pointed probe, a more rounded probe, so you can create risks in the composite to help you. and again use the K-light. And here you can start using this other burr, this here, okay, with this reference that you can check back later, so you can remove without being so aggressive to animal, and then K-light and removing, K-light and removing. This way, and then start polishing. This is the best way for you to remove attachment. This one is an astropol polisher, okay, for you to do the initial polishing, and then a shofu to finish. And we can achieve this kind of outcome. This is beautiful, right? So imagine that the tooth is a perfect position and like new, like it always is, without any signature of a bad job when removing the attachments, okay? So this must be our goal. You probably need to schedule 1 hour to remove the attachments, to do this procedure with time, okay? But it's completely worth it. Before we finish, okay, and talking about staging, this part, I like to comment that it's something that we're going to discuss over all other webinars, mostly from the 5 to the 12, when we're going to talk how to treat specific malocclusions, because it's part of the process. So it's important for you at this point to understand the concept, okay? And staging, when we talk about aligners, is basically understanding how teeth is going to move from the initial situation to the final situation, okay? Sometimes we know in the map, we can point in a map where we want to go. So I am here in Madrid, I want to visit you in Estonia, okay? My wife is from Estonia, we're planning a visit. So I know I want to go here. So I understand my final destination. The staging is putting these on ways, the software, the app, that can go do the map, how I'm going to get there, okay? So staging is exactly this when talking about aligners. If we are going to move, sorry, all teeth together, if I'm first going to move the cuspid and then I'm going to move the lateral, it's the coordinating our movements to do it the best way possible, okay? Ideally, we should move all together, right? It's going to save time. If we can do all movement at the same time, as you can see in this video, okay, when we are expanding, okay, so the plastic is pulling, is pushing in the back and moving out. So this is something that we can do at the same time, okay, because they are very synergic. So for alignment, leveling, anterior intrusion, cross bite, for permanent dentition is something that we can create a staging where you can see here in white is where the tooth is moving, and you can see that all of them are starting in white in the first aligner, here 0, and they are moving until the end of the set of aligners together, okay? Here, other case, we are moving to distal. Just by look to this image, we can understand that this kind of movement where we can see the full upper arch moving back together, it's not possible. It's again physics, right? We don't have a proper biomechanics here. And this is something that the artificial intelligence of the company, the technicians, they proposed to me. How can we move back all the maxilla for an adult patient together? It's not possible, it's not going to happen. Only if we have skeletal anchorage, if we are doing this by orthodontic surgery, and this is not the case because we are planning here orthodontic movement. So how can we make it more predictable? Okay, we need to create what we call sequential movements. Okay, so when it's not possible to move all teeth at the same time, for mesialization and distalization, okay, I'm talking about aligners here because we have other tools that can be possible to do this. If we want to treat with aligners, to mesialize and distalize, we need to do sequential movements, not move all the quadrant at the same time. In the mixed dentition for crossbite, because we can easily lose the predictability of the sharp cross, so we need to have the movements in a sequential way to keep a better anchorage. Okay, for anterior retraction, so we want to move all the anteriors, all the maxilla back. Okay, so it's not possible. Anterior intrusion with retroincline. So this is something that we're going to repeat with explaining the treatments. But when we need to intrude and the crown is retroincline, if we start and the roots are out with buccal torque, we first need to correct the inclination and then intrude, okay? And also the same for anterior extrusion with procline anterior, okay? So basically, sequential movements is creating some order on how people are going to get in here, okay? So we need to move, how to move teeth is as important as where to move. But just understanding that I want to go to Estonia and then I decide to go by bike is not a good idea, right? I need to figure out how I want to get there, okay? And also, it's important because a lot of times when I'm treating cases with the treatment planning service of DST, we are implementing strategies, okay? And then we understand for this kind of malocclusion, we need to create a sequential movements. First move this one, use the other anchors. Then when this one achieves the position, we need to start the other. Of course, this is going to increase the number of aligners, okay? Because if we are doing all movements at the same time when it's possible, we can simplify and reduce the number of the aligners. And this is, of course, faster. But when it's not possible to do all at the same time, although it's going to increase the number of the aligners and it may look that it's going to take longer, in the end is going to be faster because the other way is not going to work. And then we're going to repeat and repeat, okay? So, to build the treatment staging, okay, we have pretty much two options, right? If you are using do-it-by-yourself software, okay, like SureSmile, Nemotech, the advantage is that you can control everything. And then also, it's the cost of the material. It's not as expensive as ordering from Invisalign, Spark, and even SureSmile for the service that they have. They have the two options, okay? And the against is time consuming, okay? To do a good staging, good treatment planning, place attachment and everything in a do-it-yourself software requires a lot of high-end lab equipment, expensive softwares, and you need your time. That is the most expensive asset, okay? So if you have these equipments, if you have time, you can invest this time to do everything by yourself, to adjust the way tooth is going to move. You need to do a training to do that. It's not easy. It takes a lot of time, but it's possible, okay? Option number two is to use a third-party lab like Invisalign, Spark, and again, SureSmile, because you're going to save a lot of time, okay? They're going to offer you high-end material because they invest a lot for the plastic and everything else. They are doing millions of cases, so the artificial intelligence to calibrate the force, it's better than what we are doing by ourselves. Although we are orthodontists and we study a lot, they have a lot of orthodontists all over the world using their brains for them to improve this, okay? And you don't need to invest in any lab material equipment. So you can ask your patients to invest on it, and they like to invest in this kind of material because it's kind of cool and it's good for everyone. And the against is that the cost of the material to order is higher, of course, and to create the staging, you need to communicate with the lab. You don't have more the control to do the staging. You need to ask the technician there to do what you want, okay? And the communication is a key factor. You need to know how to communicate, okay? So this is the final tips here about staging that you maybe can use tomorrow if you want, okay? But it's going to serve for us to understand how we're going to plan the cases in the future webinars, okay? So you need to follow these 4 steps here when we are going to write to the company asking for some specific staging, okay? First, you need to set your goal, okay? Then specify how to achieve your goal, and then avoid generic language, and then ideally organize your idea. So let's review. To set your goal, you need to describe with details what you want to perform, including the tooth number, the arch, and everything else. Now, for example, if you want to create a sequential movement in the first quadrant, you need to start saying this. Do sequential distalization, in this case, on teeth 1.7, 1.6, 1.5, 1.4, 1.3. You need to explain where you need to create this in order to improve the predictability. And this is the knowledge that we have. I'm going to show you how to do this in a few, okay, webinars, but this is the first part. Here I am setting my goal. I want to distalize the first quadrant, and I want to distalize this group of teeth, okay? And then how I want to do this? I can do this by moving only the 1.7 to the final position, then moving the 1.6 to the final position, then moving the 1.5. Of course, this is going to take more time, okay? Or I can use another protocol. Depending on the situation, I like to use one or another, okay? So it's important to specify the amount of movement, because if you just say do sequential movements, the technician won't know. He won't know how much you want, and when he starts the order, he's going to do some average thing that he is going to do for all cases, okay? My recommendation is to use the 50% pace, okay, which is start the next tooth after the first one achieves 50%. This way, when imagine the 1.7 achieves 50%, we start moving the 1.6. You will still have the 5, the 4, and the 3 there being used as anchorage. And when the 1.7 achieves 100%, the 6 is 50%, and the 5 start moving. So you have the 7, the 4, and the 3. Again, 3 teeth being used as anchorage. So you always have 3 or 4 teeth being used as anchorage to move 1 or 2. And this is going to increase predictability. Avoid generic language. Okay, so be specific with the description. The technician is not a dentist. Okay, so if you say distalize a little or distalize fast, slow, he won't understand. So you cannot write terms of improve the occlusion, correct the class 2. You need to first, if you can in your software, move by yourself to the position you want, the ideal. If you don't have this, you need to be very specific about how much you need to distalize. You need to measure in the screen. You need to say, I want to distalize the molar 3 millimeters. And then he's going to do this, okay? And finally, remember, everything you write to them is like a document. And you need to be very clear. And the best way I know to do this is to be organized. So you can put by bullet points here. So number 1, do this. Number 2, remove the tooth 1.8. You can organize your ideas so it's going to be easier for them to understand, and also it's going to be easier for you to review later what you ordered and to compare if they actually did it, okay? Well, with some minutes after, okay, today this is the topics I like to bring to you. Now, Valeria, sorry, I surpassed a little bit the time and the team, okay? Say sorry for everyone, but I think it's important for us to provide the most amount of information about each topic. And I'm open here to answer the questions if we have any, okay? The first one, could you explain about photography? What would be the basic photography for planning according to the new concepts in dynamics and positions of incisors for planning? Well, in the first webinar, I discussed a little bit about the kind of photography that I like to use, okay, to guide my diagnosis, okay, my planning, okay. I shown to you that even though for most companies, they accept the basic documentation for orthodontics and it's okay for them, they are, most of the time, they are leveling the model with the horizontal line of the floor, and then we lose a lot of reference about the natural head position, okay? So I don't use a fancy camera for photography, okay? I use a regular camera, sometimes even my smartphone, my iPhone, okay? And I like to have the patient in a very comfort position. I have them in a very, I try to place them in a, I place the camera the same height of their eyes to keep them in a comfortable position. I don't want them to look too much up or too much down, okay? I need to have in the same level of me so I can see them talking. I like to record videos also to to understand where it is the most natural position. So later, if I need to change rotate the photo, okay. And I use the protocol for DSD, Digital Smile Design, where I take 5 photos, okay. 2 of them frontal view, 1 full smile, okay, showing a lot of teeth and showing the bite open, so I can see the black behind the upper arch, okay. Then in the frontal view in rest position, but in rest position with the lips open, like the patient when they are about to start talking, like this. So I can understand with these 2 photos the maximum exposure of the gums, if they are exposing or not, if we have margin to increase, intrude or not. In the rest position, if I can extrude or intrude, because if the patient already are showing their incisal edges in rest, I cannot extrude more, and sometimes they are not showing anything, I cannot intrude. So with these 2 photos, I'm doing the vertical diagnose, okay? Then I like to take 2 photos in profile, one in the rest in the same way with the lips open, and other in the full smile. So the same position of the head of the patient full smile, I take frontal view and in profile, and the rest showing with the lips open in frontal view in profile. And also I like to use what DSD, I believe they invented, the 12 hours, the angle that takes from above. So we can see in this angle, the camera coming like here, like I'm showing to you in the webcam, the relationship of the upper incisor with the lower lip to understand the anteroposterior. Okay, so the profile also to understand the anteroposterior. Okay, and with these photos, I can calibrate. Then I am using the collaboration with DSD, and then in the Nemotech software, I can overlap the STL file with the photo in the full smile, so I can have in the model the natural head position, and then transfer this to Invisalign, okay? If you don't work with DSD, if you don't work with Invisalign, the best way to do is by using a software that you can have 3D controls, you can change the position of the models, okay? And then take these pictures, or the most complete amount of pictures and videos you can have to understand the smiling of the patient in rest, in the full smile, in the photo smile, and try to equilibrate the position of the model according to the photo, okay? So this is how I am adapting and adjusting the incisors in my planning, okay? I define the vertical, the anteroposterior with these pictures. By overlapping the upper model, STL file with the photo, I can transfer this, and by using DSD Invisalign, I can transfer this to Invisalign where I'm going to plan. If you didn't saw the first webinar, you can have some ideas. I recommend you to take a look there, okay? And of course, this is not a topic of this course. We are more talking about aligners, but it's a very important topic for orthodontics because it's going to guide our decisions, okay? And just complementing this, since we didn't, I don't have any other question for now. My diagnosis is going to base on the position of the upper incisor. Okay, when I understand that the ideal position of the upper incisor is in this position, according to the face, the anteroposterior, the vertical, this is going to define the position of the whole upper arch. Okay, and then after that, I will understand the diagnosis. For example, if I have a class 2, but the incisors, where they are in a good position according to the face, I'm not going to correct this class 2 by retracting the uppers. Okay, I need to understand how I'm going to adapt the lowers. If there is a growing patient, I can use orthopedics. If it is an adult, I need to consider surgery. So they're going to guide my diagnosis. Okay, because one of the rules of the airway, that is a very trendy topic about airway issues in sleep apnea, is never move back, never reduce space, always expand, always gain space to avoid issues in the airway, okay? So if the class 2, we have the maxilla in a good position, we don't have a procline incisors, and we don't have margin to retract, I'm going to leave them in the best position according to the airway and the face, and then I'm going to figure out how to solve the case. I hope I can answer your question. And regarding the topics today, anything else? Any question? Well, since we don't have any questions and I'm surpassed the time, I don't want to leave the team there more time than they need, okay? But if someone looking this webinar later and not live has any other question, you can use the chat there in the platform of OHIS or write to the team and they can write to me and I can help you as much as I can, okay? It was a pleasure to be with you today. I hope I could bring some good tips for you. Next webinar, we are going to discuss about additional strategies over like elastic, byte ramps, fake attachments, and also about the software itself and how we can use all these concepts together, okay? It will be next week, and I hope to see you there, okay? Bye-bye.